Your patient's urine output has dropped from 60 ml per hour to 15 ml per hour. That's not just dehydration, that's a red flag in their that the kidneys might be shutting down. And if you don't catch it early, acute kidney injury can progress to full renal failure in hours. Hi, I'm Tochi. I'm a nursing student. I am preparing for my critical care exams, and today we're going to be breaking down acute kidney injury, also known as AKI. This is the condition that happens in 20% of ICU patients. It can be caused by medications you give, and it requires you to spot the warning signs early. Now, in the next few minutes, I'm going to show you the 3 types of acute kidney injury and how to tell them apart, the labs that matter, not just BUN and creatine, what you do when you suspect acute kidney injury. No complicated terminology. I'm going to try to keep it as simple as possible. This is not a boring lecture. It's just simple, clear explanations that will help you on your exams and on the floor. Now, let's go. Okay, acute kidney injury, let's start with the basics. Acute kidney injury is a sudden decrease in kidney function. We're talking hours to days, not months or years. Your kidney normally do 3 main jobs. 3. 1, they filter waste from your blood, creatine, urea, toxins, all that gets removed through the urine. You pee it out. Number 2, balance fluids and electrolytes. Sodium, potassium, water. Kidney keeps everything balanced. 3, regulate blood pressure and make red blood cells. They produce hormones that do both. Now, when acute kidney injury happens, all of this stop working properly. So what do you see? You see decreased urine output. You see that's the oliguria. It's less than 0.5 ml per kg per hour. You see fluid overload. That's when you see puffy, swollen ankles, like in the legs. You see the edema, and you see crackers in lungs. Electrolytes imbalance like high potassium, which is very, very dangerous. And then you see waste buildup like BUN and creatine. And we also see metabolic acidosis. That's when the body becomes too acidic. And here's the scary part. Early acute kidney injury might have no symptoms, like there's no symptoms, your patient looks fine, but their labs is screaming trouble. That's why you need to know what to look for. Now, acute kidney injury is divided into 3 types based on where the problem is. So there's pre-renal acute kidney injury, there's intrarenal acute injury, and then there's post-renal acute kidney injury. Think of it like a pumping system. Pre-renal is the problem before the kidneys. There's not enough blood flow. Intrarenal is problem in the kidneys. That's kidney damage. And then post-renal is the problem after kidney. There's blockage in the tubes. Let me break each one of them down for you. Pre-renal acute kidney injury is the most common. 60 to 70% of the case of acute kidney injury is caused by pre-renal. This is when the kidneys are not getting enough blood flow. Think about it like kidneys filter the blood. If the blood flow drops, kidneys can function. What causes this? Hypovolemia. That's the low blood volume. What that means, they're dehydrated. Your patient is dehydrated. They're bleeding somewhere. The internal bleeding. There's vomiting, like they're constantly vomiting and they're having diarrhea. Decreased cardiac output, that's when the heart is failing or the patient is in cardiogenic shock. Vasodilation, that's maybe the patient has sepsis, they are anaphylactic, maybe they took something they're allergic to, and they're reacting, the blood vessels are too relaxed. Think when you get vasodilation, think of when something is relaxed. Well, the blood vessels are relaxed. Medications like NSAIDs, ACE inhibitors, they reduce blood flow to kidneys. Now, the clinical signs to watch for: tests, dry mucous membrane, low urine output, but kidneys are structurally fine. They're okay, but there's low urine output. Low blood pressure, tachycardia. Tachycardia is when the heart rate is fast and high. So let's say a patient, the normal for an adult, the normal heart rate is 60 to 100. If the patient is, let's say, 120, that's tachycardia. Above 100 is tachycardia. Elevated BUN and creatine. That means the BUN rises more than the creatine. The good news, this is reversible. If you catch it early, give fluids, improve cardiac output, fix the blood pressure, kidneys will bounce back. Now, the second one, intrarenal acute kidney injury, is intrusive. That means the damage is to the kidney itself. This is when the kidney tissue is damaged. Something has hurt the nephrons, that's the filtering units. And what do you think can cause this? What causes this? Acute tubular necrosis, ATN, is the most common one. That is when there's prolonged hypotension. The kidneys are starved of oxygen. Nephrotoxic drugs, that's like when I think nephrotoxic drug, I think vancomycin. I think amyloglososides, those are your gentamicin, contrast dye, chemotherapy, it's the glomerulophosphates. It's the infection or autoimmune attack on kidneys. Acute interstitial nephrosis is the allergic reaction to medications. Clinical signs: urine output drops significantly. The urine may have protein, blood, or cast. Cast is cellular debris. Both BUN and creatine rise, but creatine rises more. Kidneys are damaged, so recovery takes longer. This one, the intrarenal acute kidney injury, is scarier because kidney tissue is actually injured. It can take weeks to recover or may not even fully recover. Now, the third one, post-renal acute kidney injury, is the obstructive blockage in the urinary tract. Now, kidneys are working fine, but urine can get out. Think of a clogged drain, like when you wash your hair in the shower and your hair clogs the drain. Yeah, that. The sink works, but water backs up. What causes this? Well, kidney stones. It's blocking the urethras. Enlarged prostate, BPH, blocking urethra, bladder tumor, blood clots, kinked or blocked urinary catheter. Now, the clinical signs to watch for is the sudden drop in urine outputs, like from 60 ml to 15 ml per hour. Ding, 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 ding. Complete anuria, that's there's no urine. Bladder distension, patient is uncomfortable, they feel pressure. Flank pain, flank it's here, right? I don't know if you guys can see me. Yep, nope, you can see me. Okay, flank pain is right here, or lower abdomen pain. Hydronephrosis on ultrasound, that means the kidneys are swollen with backed up urine. The good news is once you remove the blockage, the kidney usually bounce back, recovers quickly. So to recap, pre-renal, not enough blood to the kidneys, so we have to fix blood flow. Intrarenal, kidneys are damaged, we need to support and wait for healing. Post-renal, urine can get out due to blockage, and hence we have to remove blockage. Now, make sense? Good. Let's talk about how you assess for this. Okay, so your patient urine output is dropping. How do you figure out if it's acute kidney injury and what type is it? Well, check output trends. Your normal is 0.5 to 1 ml per kg per hour. For a 70 kg patient, that's 35 to 70 ml per hour. Oligura is less than 0.5 ml per kg per hour. So anura is less than 50 ml in 24 hours. Like, you don't want to wait that long. If you see urine output dropping over a few hours, don't wait, start assessing now. Your number 2 step, check labs. The big 3 labs related to kidney is your BUN, that's your blood urea nitrogen. The normal BUN is 7 to 20 mg/dl. So BUN is for its waste product from protein breakdown. The kidney filter this out. Creatine, your normal is 0.6 to 1.2. This creatine is a waste product from muscle metabolism. It's the best marker of kidney function because it's very, very specific, you know. Then your third one, BUN to creatine ratio. Your normal is 10 to 1, 20 to 1. Now for pre-renal acute kidney injury, greater than 20 to 1, that means your BUN is rising more because kidneys are trying to conserve fluid. And then if it's intrarenal, it's for intrarenal acute kidney injury, less than 10.1 or 10 to 1, it means that both rise, but creatinine is rising more because nephrons are damaged. Did you understand that? It sounds a bit confusing. Let me say it again. So the BUN to creatinine ratio is normal is 10 to 1 to 20 to 1. That's the range, 10 to 1 to 20 to 1. So if for pre-renal acute kidney injury, greater than 20 to 1 is that the BUN is rising more because the kidney are trying to conserve fluid. Remember, pre-renal is the kidney is not getting enough fluid. Now intrarenal, that's inside, acute kidney injury, so less than 10 to 1, it means that both are rising, but the creatinine rises more because the nephrons are damaged. Capiche? Other labs to monitor for is your potassium. You need to be watching for hyperkalemia, which is very dangerous. Kidneys can't excrete potassium, so it builds up and then it can cause deadly. So now see, when there's too much potassium, it starts affecting your heart. You don't want that. So it can cause deadly arrhythmias. Critical potassium will be above 6.0 MEq. Now, for what you want to be looking for in your urinalysis for pre-renal is concentrated urine, high specific gravity. For intrarenal, we're looking for protein, blood, casts, signs of damage. For post-renal, you may see blood if there's stone, if the blockage is by kidney stones. And the reason why you see blood is because the stone is not like gravel. Kidney stones is sharp, so it scratches. The scratch is the blood you see. The scratching when it goes down the tunnel is the blood you see. Now GFR, that's the glomerular filtration rate, measures how well your kidney filters. Your normal is 90 to 60 ml per minute, and if they have acute kidney injury, it just drops significantly. Now, number 3, you want to assess the patient. Fluid status. If they're overloaded, you would hear crackles when you hear crackles in the lungs when you ossicate them. Edema, weight gain, jugular vein distension, JVD. If they're dehydrated, dry mucous membrane, poor skin turgor, and low blood pressure, so they will be hypotensive if they're dehydrated. Now, medications. You want to assess, are they on nephrotoxic medication like gentamicin, vancomycin, NSAIDs, contrast dye. Urine characteristics, is it we're assessing for color, we're assessing for clarity, we're assessing for amount. Pain, do they have flank pain? If they're complaining of flank pain, think obstruction or stones. Now, and here's something critical. Trend the labs. One, elevated creatine doesn't mean acute kidney injury, but if creatine was 0.9 yesterday and 1.8 today, it has gone twice the, I don't know, the math, but it's 50% increase. That is acute kidney injury. You cannot just go from 0.9 yesterday to 1.8 today. No, it's, so that's acute kidney injury. So catch it early and you can reverse it. Now, treatment. What do you do? So you've identified acute kidney injury. Now what? Treatment depends also on the type of acute kidney injury. Pre-renal acute kidney injury, you want to restore blood flow to kidney by giving IV fluid, bolus normal saline or lactated ringers to increase blood flow. You want to treat the cause. Are they hemorrhaging, internally bleeding? Is that why they're having low blood flow? You want to transfuse blood. You want to give them RB, red blood pack cell. You want to transfuse blood. Is it heart failure? You want to diuresis them and give them inotropes like dupotane and dopamine. Sepsis, well, we want to do the sepsis protocol. We want to give them fluids, we want to give them antibiotics. And if it's medication, then you need to stop it. You need to stop nephrotoxic medication like NSAIDs, like ACE inhibitors. And you want to monitor urine output closely because our goal is to return to 0.5 and above 0.5 ml to 1 ml per kg per hour. Now, if it's intrarenal acute kidney treatment, for acute kidney injury, the treatment would be to support, the goal will be to support the kidneys while they heal. So the goal, no, the treatment, the goal is to support the kidney while they heal. The goal will be to stop offending agents, contrast that nephrotoxic drug, fluid replacement, balance is key. I mean, fluid, no, not replacing. Fluid management. Balance is key. Too much fluid can cause pulmonary edema. Too little fluid can worsen the kidney perfusion. So you want to, it's that thing where you're like trying to be like this or not like this. 6, 7. I don't know why that came up. Diuretics of like furosemide, Lasix. I hear that name a lot. If fluid overloaded, you need to treat electrolyte imbalance, especially hyperkalemia. I don't know if you've noticed how many times I said hyperkalemia already in this short span. You want to monitor for complications. Metabolic acidosis may need sodium bicarb. Uremia, that's the buildup of toxins. It can cause confusion, nausea, pericarditis. If kidneys are not recovering, dialysis. And there's this thing I learned recently that I didn't know before. Dialysis is a life support. So, we need to let our patient know that. Okay, moving on. Number 3, the third one, post-renal acute kidney injury treatment. The goal will be to remove the obstruction. And we can do that by doing Foley catheter. If it's bladder outlet obstruction, if the Foley is the one that is kinked or blocked, you unkink it. That's what I mean by that. Nephrostomy is like the nephrostomy tube or urethral stent. That's if it is upper tract obstruction. Surgery if there's tumor or large, or if the stone is too large to like come out itself. You also want to monitor urine output after relief. Like you want to watch for post-obstructive diuresis. That's the massive urine output. Once blockage is removed, you need to replace fluids. Now, let's talk about your nursing priority. Priority 1, monitor intake and output strictly every single hour. You need to know exactly how much is going in and exactly how much is coming out. Same time, you need to do your priority. Your second priority is daily weight. So remember, your first priority is intake and output. Your second priority is daily weight. You need to weigh them same time, same scale, same clothes, or lack of, if it's possible. So if they have 1 kilogram, excuse me, I'm so sorry, 1 kilogram weight gain, that's 1 liter of fluid retained. That's not good. Priority 3, you want to watch for hyperkalemia, because high potassium is deadly and it can cause cardiac arrest. Signs of hyperkalemia is muscle weakness, irregular heartbeat, EKG changes, tall peak T wave. So instead of it to go this way, it's going, yeah. If potassium is above 6.0, give calcium gluconate IV to help protect the heart. So the simple way to think of this is DICS, but it doesn't go that way, but it's like a good acronym for it. DICS is dextrose. DICS, DICKS, dextrose, insulin, calcium gluconate, calicylate, and then S is sodium bicarb. So the first one you want to give is calcium gluconate to protect the heart. Then you give insulin. Well, you check their blood sugar. Then you give, because if it's someone that does not have like an healthy patient, you want to check if it's low. You give them dextrose to increase the blood sugar. Then give them some time, 15-30 minutes, then give them insulin because you do not want them to crash. Yeah, I learned that. And then that's basically the reason why we're doing the insulin and the dextrose is to drive potassium into the cell. Then sodium, cassylate is to it binds with the potassium, and then you poop it out. And then sodium bicarb is to, if it's too acidic, to base it out. So basically prepare for possible dialysis if needed. Your fourth priority is avoid nephrotoxic medication. Hold or avoid NSAIDs like ibuprofen, tramadol, Tylenol. Oh wait, no. Yeah. Amigdalosides like gentamicin, carbamazepine, vancomycin. Monitor levels closely. For conscious dive, imaging needed. You need to pre-hydrate patients. ACE inhibitors or ABs in acute setting. Priority 5. Monitor for fluid overload. Listen to the lungs every shift. Crackles means there's fluid in the lungs. Check for edema. Face, hands, ankles, sacrum. Watch for increased work of breathing. That is when they're breathing more. Daily weight trending up. That means they're retaining fluid. Now, priority 6. Prepare for dialysis if needed. Dialysis indication, AEIOU. That's the word that helps me. A. Acidosis. Metabolic acidosis not responding to treatment. E. Electrolyte imbalance. Hyperkalemia. I. Intoxication. Drug overdose that dialysis can remove. O. Overload. Fluid overload causing pulmonary edema. U. Urema. Toxic buildup causing symptoms. Basically, what are the things that would make you or make a doctor decide a patient needs to be on dialysis? AEIOU. Acidosis, electrolyte imbalances, intoxication, overload, urema. AEIOU. Now, if your patient needs dialysis, your job is to maintain vascular access. That is dialysis, catheter, or fistula. You want to monitor during treatment. Hypotension is common. Watch for bleeding. Heparin is used during dialysis. Provide education and emotional support. Now let's talk about what can go wrong and what recovery looks like. Complications of acute kidney injury is fluid overload. Then when you have fluid overload, pulmonary edema then causes respiratory failure. Now another complication you could have is hyperkalemia. Too much potassium in the body, it increases risk for cardiac arrhythmia, boom, cardiac arrest, MI, heart attack. Metabolic acidosis, boom, multiple organ dysfunction. Urema, boom, confusion, seizure, pericarditis. Infection, patients with acute kidney injury are immunocompromised. Chronic kidney disease, if the kidney does not fully recover from Intrarenal AKI. You have chronic kidney disease. Prognosis: pre-renal AKI, they have 90% recovery if treated early. Intrarenal AKI, they have 50 to 60% recovery, but some may develop chronic kidney disease. And post-renal acute kidney injury, 95% recovery once obstruction is removed. So basically, the worst one is when the kidney itself is damaged. Now, the key is early recognition and treatment. You, the bedside nurse, are often the first to notice urine output dropping. You are the one who catches the trend, and your vigilance can save kidneys and life. Now, let's recap what you need to remember. 1. Acute kidney is a sudden drop in kidney function, hours to days. 2. There are 3 types of kidney injury. Pre-renal, not enough blood flow, it's the most common one. Intrarenal, kidney damage. Post-renal, obstruction. 3. Key labs is BUN-Creatinine, BUN-to-Creatinine ratio, electrolyte like potassium. 4. Watch urine output like a hawk. Less than 0.5 ml per kg per hour for 6 hours. Ding, ding, ding. Red flag. 5. Hyperkalemia is the most dangerous complication because it can cause cardiac arrest, also known as myocardial infarction, also known as heart attack. 6. Treatment depends on type, but always restore perfusion. Stop nephrotoxic medication like vancomycin, NSAIDs, manage fluids and electrolytes. 7. Dialysis indication, AEIOU, acidosis, electrolyte imbalance, fluid overload, uremia, infection, AEIOU. Got it? And that is acute kidney injury simplified. If this helped you understand acute injury better, please hit that subscribe button. I am posting nursing study session with me videos every week. Next week we'll be talking about more stuff. Prepare to be amazed. And please drop your questions in the comments. What part of acute kidney injury is still confusing? I read every single comment and I'm going to respond if needed. And hey, you're doing great. Critical care is tough, but you're learning, you're preparing, and you're going to be an amazing nurse. I will see you next week. Keep studying, stay positive, and remember, you got this. Peace. Oh. I'm trying to be professional.